Hello, everyone, and welcome to today's live broadcast, setting up next-generation sequencing for the needs of routine molecular diagnostics with a focus on the suitability of the GeneReader NGS system for lung cancer patients. Presented by Dr. Paul Hofman, head of the Laboratory of Clinical and Experimental Pathology at Pasteur Hospital and head of the Human Biobank Unit at Pasteur Hospital. I'm Dr. Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots and sponsored by QIAGEN. For more information about our sponsor, visit them at www.qiagen.com. Before we begin, I want to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen, type the questions into the drop-down box that appear on the screen, and we'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing the presentation, just click on that Help Desk button located in the permissional board at the bottom center of your screen, or use that Ask a Question box and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Click on the Continuing Education Credits tab located on the top right corner of your presentation window and follow the process to obtain your credits. Please join me now in welcoming our presenter, Dr. Paul Hofman. I will now turn the presentation over to him. Welcome, sir.
Okay, good morning, everyone. So this presentation aims to show why it's important to set up a next-generation sequencing approach in a molecular pathology lab today and how to do that. So more specifically, I will present our own experience in our pathology laboratory with a special focus concerning the use of the GeneReader NGS system for lung cancer patients taking care. So here is the agenda of this presentation. I will start with a summary of some major points concerning the lung cancer in 2018, then a practical point of view of using the GeneReader NGS system in a pathology lab, and finally, some studies which compare different NGS platforms. So in introduction, I would like to stress some global points concerning the lung cancer in 2018. And indeed, it's important to keep in mind what is the lung cancer landscape in 2018. So it's well known that lung cancer is still the main cancer killer worldwide, and despite new promising therapeutic strategies, the prognosis of late stages lung carcinoma is very bad, with an overall survival of less than 2% of the population 5 years after the initial diagnosis. And despite many campaigns of prevention to combat tobacco addiction, in particular among young people, the lung cancer death rates among European women increased these last few years. And it's noteworthy that now lung cancer is the first cancer killer in women living in certain European countries, such as UK or Poland, and probably in France. And moreover, the estimated mortality worldwide for 2020 shows that lung cancer will be the 5th cause of death at this time, with a dramatic increase of cases among the population in the world. So, also besides the tobacco exposure, we need to be aware that one major cause of lung cancer onset in the future will be certainly air pollutant exposure. And as you know, it was claimed by the World Health Organization in 2013 that air pollution is now a type 1 carcinogenic factor. The introduction of targeted therapy into the clinical management of lung adenocarcinoma has had a massive impact of patient care, with the discovery since 2004 of an increased number of genomic alterations. Consequently, mutational analysis is critical in 2017 for treatment decision in clinical routine practice. So it's well admitted that it's mandatory to give the right drug to the right patient at the right time, but also by giving the right approach and at the right cost. Moreover, we have to take into consideration that the turnaround time to get the results is pivotal and should be less than 10 days for a couple of mutations. And since some non-invasive liquid biopsy may be used in certain situations, we have also to take into consideration the nature and the quality of the bioresource used for genomic analysis. In this context, many samples can be used for molecular biology technologies such as tissue biopsy, cytological samples, and some biofluids, in particular blood samples. Concerning the usefulness of liquid biopsy for lung cancer patients taking care, the main interest is currently for EGFR mutation testing. But besides this point, many other opportunities will be possible in the next future, such as liquid biopsy for screening of early diagnosis of lung cancer, and also large genomic alteration analysis using next-generation sequencing technology. So the assessment of circulating tumor DNA in lung cancer patients can be made using different technologies showing various sensitivities, but also different specificities. For example, the droplet digital PCR method, which is best for individual point mutation detection and which needs a minimal bioinformatics development in the lab. Currently, there is 2 approved companion diagnostic tests for EGFR detection in liquid biopsy. This is the TerraString test and the Cobas test V2 kit. But finally, NGS method can be developed from circulating tumor DNA using different panels. In theory, this approach allows the detection of point mutations, rearrangements, and genomic amplification. I will focus this presentation to lung cancer patients taking care, and as shown here in a recent issue of the Journal of Clinical Oncology, molecular testing guideline for the lung cancer patients includes first the need for EGFR mutation detection, ALK and ROS1 rearrangements detection, and BRAF mutation detection. Of course, beside PD-L1 immunohistochemistry testing. Moreover, other biomarkers such as HER2 mutation, RET and NTRK rearrangements, and MET mutation and amplification are currently under investigation as predictors of response to targeted therapy. So, for molecular testing in a routine practice, 2 different strategies can be set up for solid cancer patient taking care. First, a strategy using a targeted analysis, and secondly, a strategy using large panel sequencing. As shown on this slide, for targeted analysis, different devices can be used with different sensitivity efficiency, allowing us to get the results with different turnaround times. For panel sequencing, different NGS sequencing systems can be used routinely from different companies, such as the MySeq from Illumina, the PGM Ion Torrent, and now the S5 from Thermo, and finally, the GeneReader sequencing system from QIAGEN. So now, the second part of my talk will focus on the use of the GeneReader for NGS approach, mainly for solid tumor genomic alteration, and we set up this GeneReader system in our lab. Here is a GeneReader system, and in our experience, the workflow takes 5 days until the diagnosis can be made. In our in-house pipeline, protocols and reagents used in the different steps of the pipeline have to be synchronized. Globally, there is a very low hands-on time, less than 10 hours, but a hands-off time of nearly 60 hours. So different applications are currently available, and we started to develop in our lab some of these applications, in particular the Actionable Insights Tumor Panel. Of course, other applications include some panel from lung cancer and very soon a myeloid panel. Since most of our activity is focused in lung cancer patients, we think to use very soon the UMI all-in-one assay, allowing detecting mutation and rearrangements both in tissue and also in liquid biopsy. So this table shows the number of variants detectable according to the UMI DNA panel and to the QR-ACT AIT V2 panel. As you can see, all the genomic alterations of interest for lung cancer are present in both panels, with more variants detectable in the AIT V2 panel. For summarizing the second part of the presentation, we can say that the targeted NGS workflow of the GeneReader system has low hands-on time, but a relatively high hands-off time currently. It demonstrated a high run performance and a high accuracy in mutation calling. The GeneReaders allow the integration of an automatic data transfer and automatic analysis and an easy interpretation for the team in the lab. So in this context, the interpretation, so the QCA, enables to report easily the mutant with a potential pathogenic impact according to the previously described CAP-ASCO guidelines. So for us, it's an easily accessible technology for all molecular pathology laboratories. So for better evaluating the GeneReader NGS system, different comparative studies have been recently published, and I decided now to select a couple of them. The first publication, made from some investigators of the Institute of Pathology in Cologne, Germany, was set up in order to compare the GeneReader and an alternative in-house NGS platform based on the Illumina MySeq. Solid tumors coming from different pathologies such as lung, colon, gastric carcinoma, and melanoma too were included in this comparative work. The panel used on the GeneReader was the Actionable Insights Tumor Panel described previously. This quite busy table shows the time course of the in-house pipeline and the GeneReader NGS system workflow. So numerous automatic steps reduce the hands-on time of the GeneReader workflow, but one of the major points is certainly an easy step for data analysis, interpretation, and reporting with the GeneReader system. These graphs show the very nice concordance between the in-house workflow using the MySeq platform and the GeneReader system, in particular for the direct allele frequency comparison. So a high concordance was obtained for 45 clinical different variants. We recently made in our lab another work, and it was a comparison study between the results obtained using the Oncomine panel on the PGM ion torrent and the GeneReader Actionable Insights targeted panel. So as shown here, The Ion Oncomine panel contains 22 genes, and the GeneReader actionable insight panel contains 12 genes. So we did a comparison only on 6 genes. However, we highlight 2 points. First, the need of DNA amount is quite much lower when using the Oncomine panel, and currently the actionable insight panel is for research use only, while the Ion Oncomine panel is a CE-IVD panel. If requested by the delegates of the webinar, the detailed overview of the different mutations detected by the GeneReader NGS sequencing platform is now available on this recent published paper from investigators in Cologne, Germany. Shortly, here is the description of the lung cancer patient cohorts used for the comparison study between the Oncomine and the actionable insight panels that we did in our study. This comparison was made on 90 lung adenocarcinoma of different stages and including a retrospective and a prospective cohorts of patients. This graph shows the density of tumor cell content distribution between the retrospective cohort in blue and the prospective cohort in pink. Here is a description of mutational status of the 90 patients with advanced non-small cell lung cancer included in our study. We had a slight enrichment of the EGFR mutation in the prospective cohort, probably due to a higher selection in a non-smoker population. As shown here, both sequencing systems used in this study demonstrated perfect concordance for the overlapping genes with no false positive and no false negative results for missense mutation, deletion, complex deletion, and insertion. We noted too a very nice correlation of the allele frequency for all mutations found between the GeneReader and the Ion PGM, both in the retrospective cohort on the left panel and on the prospective cohort in the right panel of this slide. Finally, as shown here, the coverages at the site of mutation in the respective genes for the GeneReader and the Ion PGM were quite similar, both in the retrospective and in the prospective cohort of patients. Shortly, these graphs showed that the reproducibility of the assay performed on the Ion PGM or on the GeneReader was nice. Here, for the assessment of the allele frequency of the KRAS Q61H mutation. Once again, this figure shows a comparison of the workflow and the different times needed for the Ion PGM workflow in contrast to the GeneReader platform. The central graph shows comparison of the different steps needed for nucleic acid extraction to diagnosis, as well as required chemicals and equipment depicted in blue. So briefly, the hands-on time in gray in the upper graph is lower for the ion torrent PGM than for the GeneReader system seen in the lower graph. However, the time hands-off time was lower with the GeneReader system. So taken together, in this comparison study, we found that the total time from start to diagnosis was a little bit longer for the GeneReader system compared to the Ion PGM system. finally, we found that the GeneReader system was quite easier to use for both technicians and molecular pathologists of my lab because of a fully automated traceability for all workflow steps and because of the use of the GeneRead link. At the end of this presentation and as some endpoints, I think it's very important to say that a complete workflow for next generation sequencing should be set up in any pathology lab by 2018, in particular for taking care of late-stage non-small cell lung carcinoma patients. So in this context, we demonstrated that the GeneReader system can show real benefits of rapid workflow integration, and we strongly believe that the GeneReader can avoid the pain of harmonizing upstream solution. The GeneReader can save the expense of specialized resources to develop and optimize a bioinformatics pipeline, and the GeneReader probably can help us to realize a true solution for sequencer performance that is pre-verified within an entire workflow. And finally, the GeneReader system can document the full chain of custody from sample to inside, and this could be of strong help for getting, as an example, an accreditation for doing NGS routinely in a pathology laboratory. So thank you for your attention.
Thank you, Dr. Hofman, for that informative presentation. And we will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on that Ask a Question drop-down box located on the far left of your presentation window and type that question into the box that appears on the screen. We'll answer as many questions as we have time for. So let's get started. Let's check out our first questions coming in from our audience members. Dr. Hofman, our first question is, how long did it take to get the NGS workflow established in your lab?
Yeah, it's a nice question. So, of course, the answer depends of what you will use as a NGS system in the lab. So for me, at the beginning, we set up different NGS systems. So I will say that for me, it took around 2 months to set up an NGS workflow. But if we wanted now to set up the NGS workflow by using the GeneReader system, I will say that this time will be reduced and it will be around 1 month to do that.
Thank you very much. And our next question is, what is the biggest improvement through this workflow?
The biggest improvement is probably to get many mutation results at the same time in a short time. I will say that it's quite important that beside EGFR mutation detection of ALK rearrangement detection is pivotal for lung cancer patients to try to detect other mutation for the patient getting some targeted therapy, such as, for example, therapy against RET rearrangement or ROS1 rearrangement, and also KRAS if it's possible. So it's very important to have these results in one step. I mean, to try to detect all the mutation and all the arrangement through an NGS system. I think it's very important to improve the possibility for our patient to have the best therapy.
Thank you, Dr. Hofman. And I want to thank our live audience members for their questions coming in and remind them that any questions not answered today can be answered via email. We have one more question that has come in. Do you need a bioinformatician to interpret the results, and how do you report them?
Yeah, it's a pivotal question. I mean, it depends, of course, of your NGS system. I will prefer to have a bioinformatician in my laboratory to interpret the results, since it's a very specific area of medicine right now. So if we have some NGS systems such as the S5 of Thermo Fisher or the MySec of Illumina, I think it's definitively mandatory to have a bioinformatician to interpret the results. But for example, if we want to set up an NGS system using the GeneReader system, it's quite easier to interpret the results. So we can avoid to have a bioinformatician dedicated in the lab to interpret the results. So it depends definitively of what kind of system you want to set up in your lab.
Right. And Dr. Hofman, thank you so much for your presentation today and for your important research. Would you like to provide the audience members with any closing remarks?
No, I think I would say that it's now pivotal to set up an NGS system in any pathology laboratory or any molecular pathology laboratory all around the world. And it's a critical step right now for our patient to have the possibility to get any mutation results or rearrangement results as soon as possible, I would say in less than 10 days when we get the biopsy in the laboratory. So thank you very much.
Dr. Hofman, thank you again for your presentation. I'd also like to thank our sponsor, QIAGEN, for making today's educational webcast possible. Before we go, I want to remind everyone that today's webcast will be available on demand viewing through September 2018. You'll receive an email from LabRoots letting you know when this webcast will be available for replay. Please share this announcement with your colleagues who may have missed today's live event. That's all for now, and thank you for joining us. We hope to see you again soon. Bye-bye.